Mark Farr is going to lead this, but I've just got a couple of Open Data Saves Lives announcements to make. So from now, we're very happy to welcome Ali Morpeth, who's on the call this morning, as our lead at Open Data Saves Lives. Ali will be sharing some blog posts. Oh, if people can go on mute for a second, that'd be great. Is Ali saying hello there? Yeah. Yep. And we're ramping up the work of Open Data Saves Lives into specific projects.
Saying hi, yeah, hi.
Hi everyone. Hi Ali. And we're going to also send out a survey to people to understand what they get most out of Open Data Saves Live sessions, what projects they'd like to work on, and get this, possibly even a in-person physical event. Imagine that. So we're going to hopefully run an unconference in September here in Leeds, but we'll also be doing that live as well. So people will be able to join us. They can't do that. To review the priorities and people would like what people would like to get involved in, and then in the early 2022, can't believe I'm saying that, 2022, we'll be working on an in-person event in London with beautiful information and ourselves and possibly the Health Foundation on a larger Open Data Saves Lives in-person event as well. So I've stopped filling. Over to you, Mark.
Thank you, Paul. Sorry about that. It's sod's law that you always get your technical problems just when you're supposed to be chairing an event for 5 more people than Paul managed to get to the last one, which is always good. We've got some really good speakers, and this has all come together, as a lot of you know, through COVID. And one of the big blind spots at the beginning of COVID, I think for everyone, was care homes. And I hold my hands up to that from a linked data point of view. So part of my job is building a linked data set across the whole of Kent and Medway. And we're doing the obvious stuff like getting GP data and data from hospitals and the ambulance service and so on. And care homes is just really difficult. I had assumed that when someone from a care home arrived in our hospital, we were definitely sure they'd arrived from a care home. And when we discharged them, we were pretty sure that they were definitely going back to a care home. We have a pretty good estimate of that, but it is not perfect. You know, there's a really good paper, which I might ask Paul to put in the chat, that Ben Goldacre put out a couple of weeks ago on working out if someone's from a care home or not, you know, and it's down to, are there over 3 people aged over 65 at the same address, and that postcode looks like it might be the same as the one that the CQC have got registered as a care home. So it's been a huge blind spot and a huge area of research for all of us. I've got involved locally in Kent doing some work around digital maturity. That's led to us linking up with the NHSE in London. That led to an introduction to Claire and on to Darren. So I'm really excited that this event's come together. I'll stop there. We will monitor the chat. We will write it up as a blog. We will save and send out this webinar and all of the resources that go with it. Please, as Paul said, I would encourage a kind of an active chat, which I'll try and kind of moderate with Paul's help as we go through. 3 snappy presentations, all of about 13 minutes or so, will keep us just on time to finish on time with space for a question or 2, but probably a lot of those in the chat. So we'll go straight to Claire first from University of Hertfordshire. If you're happy with the tech, Claire, go for it. Paul and I and Grace and Ross and others are here to catch you if you fall, but the floor's yours if you want to share your screen, which is just coming through now.
Thank you very much.
Over to you.
Thank you for the welcome. I'll go straight into this and hope there'll be some chat. So the DACHA study, it started in November 2019, and we were a group of researchers who were interested in improving how we research in and with care homes, improve standardized assessment and outcome measurement, reduce waste of data, and work towards creating a minimum data set. And then the pandemic hit, and suddenly something that we thought was a niche interest suddenly became an interest for everybody. And as Mark just said, care homes have been hiding in plain sight. And what the pandemic has shown is the need for us to be able to link our routine and health or social care data with the information that we get from care homes. And I don't think we're going back. I think we're only going to go forward. So we see that making care homes part of our data systems is always going to now be a post-COVID priority. The DACHA study is reporting finally in 2024, and as Mark has just described, everybody else is moving faster on that. So one of our new challenges is keeping up to speed with that and making sure that we are developing evidence that is useful and relevant. And here there are two papers from the team. Jenny Burton talking about many of the issues that we are trying to tackle, and Barbara Hanratty giving a very good editorial on what the issues are. And I'm citing Ben Goldacre's team's report that it actually is referencing Jenny's work and the work of the Health Foundation that also had done a lot of the pre-work on postcode identification, which was a major headache for many. So I want to start with care home staff because a lot of the demand for data has come from other places to care homes. And if you look at your slide on the right, you will see that there's a long list of all the people who ask for data from care homes, which is out with the red, the data that care homes use themselves to be able to understand their residents, their priorities, and plan, deliver, and review care. And if you look to the left, it's not that we don't have standardized measures being used by care homes, but even something like the National Nutritional Screening Tool isn't recognized as valid by all organizations. So we don't really have any consensus across all these people who want care data about what is the measures that people want. And a reflection in the middle from a care home manager is expressing something that is a very consistent message, that they would like to sit around a table and discuss the data that's meaningful and how it could be shared. And that too often they are being asked for the same information in slightly different formats by different organizations and people. And an interesting reflection here that they feel that data collection has changed over time. It used to be relational, it used to be more about quality improvement, and now it's becoming more punitive and focused on monitoring. And I suppose that's a bit of a red flag in how we go forward and how we integrate our data. And just to reiterate what DACHA is really about, and I think what everybody here is about, is that we're concerned about the residents, what they want and what means most to them for their care. So DACHA, as I said, is a 4-year project. There are 5 work packages, all of which are mapping the different ways that data on residents is collected, both for service use and for research use, and drawing that together to see whether there are areas of consensus and overlap. But for purposes of time, I'm going to look at work package 3 and 4. And at the end of the slide, there'll be contact details for more detail from different people. So we've completed work package 1. Work package 2 is creating a repository of trial data for secondary data analysis. So we're now on work packages 3 and just starting off 4. And work package 3 is, if you like, looking at what we have, and there are 3 pieces of work in that. So there's a survey, and we have been delayed with that because of the pandemic, but essentially asking all care homes, what do you collect, why and how, where do you store it, and how do you share it, and how, and what are the barriers? And already in the pilot work, we're seeing the breakdown of the work that is fed outside of the care home to form aggregate data and routine data sets, and then the individual resident data that the care homes use themselves, for themselves and their organization, plus data on staff and staffing. And even as we see a growth in digital engagement from care homes, we're aware that there are hybrid systems. So some data is collected digitally, but there are still paper records in different locations within care homes. So with that survey, what we're seeking to do is just map it all out, that's never really been done, and look at the percentage and the overlap and the duplication. We've also looked at how minimum data sets have been introduced in other countries, and we know that they are good for aggregate level data. We know that they're good for commissioning and policy and planning. Not so clear about how staff can use them well for day-to-day care. And the headline findings from this work is that you probably do need a mandate, whether that's legislation or reimbursement. But if you don't have a parallel investment in support and training, then staff will just see it as a data capture exercise, and they won't necessarily understand how it can alert them to resident needs and change practice. And you also need to involve all staff and not just one gatekeeper to data capture. Clinician involvement is really important for that process, not only that they are sharing their data, but they're just using the minimum data set as the basis for discussion and review. And limited evidence on how residents themselves can have their interests and priorities entered in the data or family views. And whilst we know already that staff can use digital methods, the evidence would suggest that there needs to be more investment on digital literacy, data literacy, to actually make this work well. And Barbara Hanratty has done a scoping review of studies that have actually used minimum data sets. And I would like to show you this it's just coming out now. She's reviewed 758 studies. And I think if you look at this, this is so studies that where minimum data sets are already available in the countries where they are being taken place, mainly North America, some Australia, New Zealand, and so on. And I just think if you look at the pie chart on the right, you can see the spread of information and how it's organized and the possibilities for understanding this population and doing comparative work and targeting responses. But also, as a researcher, what I'd like to stress is that what Barbara has picked up is that there are studies that are doing quite large-scale work on residents' pain, depression, and oral health, which in this country would trigger individual work. And these are the kind of issues that are absolutely central to whether you experience the quality of care and life for residents. So now I'm coming on to work package 4, and I think this is very close to what Mark was describing at the beginning. This is led by the Health Foundation, which, if work package 3 was about the data that sits or could be collected by care homes, work package 4 is about locating the residents in our existing routine data sets, some of which the data has come obviously from care homes. And this is built from the NHS England Vanguard work, where Health Foundation did a lot of work about locating residents in data sets, and it's linking administrative health and social care records around care home residents. So you're creating a resident care home resident data set for an integrated care system using routinely care data. And the goal here is to say, if you can do this, would this reduce the demand for extra data from care homes, that others would be able to go to that resident database rather than requiring slightly different data from the care homes. As I say, we're working with 2 integrated care systems, and in work package 5, we will then develop a prototype minimum data set for 40 care homes to use and try and link it with this routine data set to see if we get a complete picture. So some of the issues for this, as this work kicks off, is that we are seeing this very much as service evaluation, and there are some very strong governance requirements that we are working through, because obviously this data is collected for direct care and secondary use has to be pseudonymized, and we cannot directly identify residents. And Richard Bryan from the Health Foundation is on this call, so if you have specific questions about that and data keys, then he can answer that. And then the other questions around interoperability, how people link, how they can interrogate and share. And whilst we are reasonably confident about healthcare standardized data, social care data varies by provider and council, and that's why we are working with 2 geographically disparate integrated care systems to see why there are commonalities and where there is the spread. And ideally, we would like to take that further to other ICSs, but we are at the moment constrained by the funding that we have. And then looking ahead, the ownership, working with those 2 ICSs, we will be showing the descriptive analysis and discussing with them the value of these data, but then and sharing the learning. But obviously the question then is the data platform and how to access to these data may be provided and going forward reviewed. Work Package 5, this is, as I say, in those two ICSs, working with care homes that are digitally enabled. And we propose to test the feasibility of collecting the kind of standardized data from care homes that can then be matched to the routinely data and assess the quality of that data and its utility for the multiple different stakeholders who now want to be able to access that information. And that's being led by Adam Gordon and Anne-Marie Towers from Nottingham and Kent, respectively. So to summarise, we know that care homes are challenged by current and increasing demand for data from different organisations, and we are hearing that questions are added every week to the capacity tracker, for example. And MDS does, we know, offer wide-ranging opportunities to enhance care at the aggregate level. We are looking to see how it can revolutionise care at the resident level as well. Data linkage, we are arguing, enhances the potential of an MDS used by care homes without overburdening them, we hope. There are already multiple measurement tools available, but there is no consensus about their use, and our review has shown that not that many standardized tools are sensitive over time for this population. We're interested in feasibility and practicality for the UK. We are very concerned about implementation to reflect the routines and needs of care homes. And we see that there is potential for the linked core data set based on resident level information that can be linked to data sources. So I'm saying thank you. Here are the contact details for the work package survey and review of MDS minimum data set. Indicators lead, that's Barbara Hanratty from Newcastle, and work package 4, the routine data set work, is Anna Walters from the Health Foundation and Richard Bryan. And there is a huge team and as you see, across national collaboration, which we are hoping that we can therefore capture all the very rapid changes that are happening and not end up being left behind by innovation. I have to stress these are my views and not those of the funder. Thank you very much.
Thanks, Claire. That was amazing. A real whistle-stop tour about what's going on. And so I'm hosting now because Mark can't work the technology again. We've got a couple of, Mark made a couple of points and I made a couple of points. So I'm going to kick off and try and my question is about data literacy. In almost every session, we talk about data literacy. I'm trying to find some good use cases for, if you like, normal people. So people without master's degrees or PhDs who understand graphs, curves, spreadsheets. What do we actually mean about giving people help with data literacy? And if you've got some good examples about that, just the my mum question, that how do we cut across that?
Okay,
yeah.
So do you mean at the individual level of care or at the aggregate level, interpreting what it means for care?
I think both. I think both. Yeah.
So DACHA was the review we did, which is what works when in what circumstances. What we found was that where the MDS had actually worked with care home staff to see how the things they were recording captured change, and that was done in real time as part of the training and support, then the care home staff would go forward and start acting on the results. But where an MDS, as happens, because in several countries it is linked to reimbursement, so it gets done as an administrative task. Where there isn't that connection, then even when the data is showing at aggregate level changes in a care home or a group of care homes, the individual staff are not reacting to it. And minimum data sets do pick up, if the assessment, depending on the timing, do pick up deterioration. So we can certainly share with you that realist review. I've just got the next draft through, so we're about to put it out for peer review, is making a very strong recommendation that yes, you need a mandate to make people do it, but it will only be an administrative task if it isn't accompanied by the kind of investment you're talking about. It says, well, when you look at this kind of assessment of pain, or this, when you use this measure, this is what it means. And if you see it shifting, this is what we could do about it.
Fantastic. I think so. I think.
Yeah. So there are people that have tested that and demonstrated better uptake of proactive care, because I think what we have in our country is that most of the data is looked at retrospectively, not in current time or prospectively at the moment.
I just can't help thinking that if we had some really nice videos on YouTube that people could share and look on their phone over a cup of tea, rather than the very academic work and that takes 4 years, that we, and I know it's amazing, but that
or
we
both,
might,
or both, Paul.
Or both, yeah. We that's my job to be, but that we might be able to accelerate and do more pace.
If people go on the DACHA study, you'll see that we are already using little animations and films.
Fantastic.
And that is part of our deliverables. I didn't have time to explain that, but I couldn't agree more. We're not expecting people to read our papers unless...
No. Yeah. I mean, to find ways of sharing that. Yeah. Mark, was there any other points that you raised?
Well, maybe in the chat, but I'm very interested in you mentioned this, Claire, that the incentives around providing the data, because of course, a lot of these patients are paid for privately, so it's quite difficult to naturally see their data. So what are the sort of contractual and research levers potentially that we can use to encourage greater use, greater participation? Dr. Robert Stewart's on this call, and he would talk about a care home where you've got patients with a good consent model around research, literally downstairs where you can go and try things out and all sorts of things. And I think there's a big opportunity, but I'm interested in the contractual levers for encouraging, a greater sharing of data around care home patients and consenting them for research. I might ask you to respond to that in the chat, Claire, afterwards, because I'm just going to try and keep time, and my internet crashing out hasn't helped that. So I'm going to go to Darren, but you might reflect some of that as well, Darren, in your topic about how we kind of keep bringing care homes into the room, which I think is what Claire was kind of talking about. So if you want to share your slides, and off you go. Thank you, Darren.
Excellent. Thank you very much, Mark, and thanks to the team for inviting us today to the ambitions for digitalising in care homes. So as the introduction said, I'm Darren Plank, and I'm a project manager for digital social care for the South East region at NHS England and Improvement. We cover 6 integrated care systems consisting of Hampshire and Isle of Wight, Frimley, Bob, Surrey Heartlands, Sussex and Kent and Medway. And that's covering approximately 3,000 care homes, care and nursing homes. I must point out that there are regional leads for this work nationally, and although the ambitions are the same, each region will approach them differently. I'm currently leading on the proxy access for repeat medication project in the Southeast, which also links with the requirements for DSPT, NHS Mail, and coordinating the various support offers that are currently in place to assist the social care providers. So if we move to the next slide, as I've been asked to talk about the ambitions, I thought it'd be good to just give a quick overview of what we're currently working on and how we're looking at the approach in the Southeast. So for us, the ambition is quite simple: to ensure that digital technology is utilised as much as possible within social care to provide the best possible healthcare to the patients, residents and staff that access it. Also taking into consideration the enhanced health and care homes model, in particular harnessing the data and technology, access to care records and secure mail, along with a better use of technology in care homes. So as you can see at the bottom of this slide, the minimum requirement for social care providers to access any of the initiatives within the ideas that are on the radar is the Data Security and Protection Toolkit. It's a really helpful annual self-assessment for health and care organisations, and shows care providers just what they need to do to keep people's information safe and to protect their business from risk of a data breach or a cyber attack, for instance. We also understand that there's some core elements that we need to get right first. So the core elements of the work alongside the minimum requirements are really important to work together. So if we look at the enhanced area, these are the items or the initiatives that are on our radar currently. So access to information in the GP record, proxy access to medication ordering, which is kind of the project that, as I mentioned, I'm working on mainly. Read access to health records and digital social care records. So all of this is in the enhanced area. Then way down the line, we're hoping to go to the enhanced plus area, which would be the digital discharge, which is commonly known as the red bag scheme. Read and write access to shared care records to give a more balanced overview of the care provider, as well as the primary care and hospital or acute setting notes, and intuitive virtual consultations. So just to move on and give it to you in a slightly different context, how we're going to get there. So this slide shows the building of the programs of work in kind of in another way. So we've started, and as mentioned by the DACHA study by Claire, we completely understand that the digital maturity and support to develop skills and capacity is really, really important. We understand that there is a very diverse group of people that work within care and nursing homes, and it's really important that we get their digital literacy right and try and support them in that. This also would give them confidence by helping them to manage the care or manage the change from a system that they've probably used for a very long time and obviously are most comfortable with. Moving up to the hardware and connectivity, at the end of last year, NHSX procured 11,000 iPads nationally, of which 1,708 homes in the southeast received at least one device. Barclays Digital Eagle stepped in, and they continue to support the care homes in using these devices, not only for residents video calling their families, which was really, really important over the last year, but also for the residents to play games and for their direct use. But these can also be used for healthcare apps such as proxy access for repeat medication, the NHS Mail, patient access for EMIS, and System Online for System 1, as well as Teams, etc. So Barclays Digital are really supporting them in making sure that they've got that base knowledge to make sure that they can utilise those initiatives as effectively as possible. Then we move to the connectivity at the bottom there. There are lots of connectivity packages out there. We realised that some homes didn't have any Wi-Fi, some have limited Wi-Fi, some are in kind of weak spots. So we've highlighted to the organisations to ensure that they've got the best possible connections to the internet and make sure that they've got a package that fits their purpose. There is a list of new internet deals on the NHS and NHS Digital Support websites, and that's specifically for care homes where suppliers will fast track to set up for care settings. That's called the NHSX and NHS Digital Support for care homes to get connected during COVID-19. So we'll come on to the, as we go into the lighter blue areas, we'll come on to the DSPT and NHS Mail in the next few slides. Just wanted to mention the system outputs and resident outcomes that we measured from acute and primary care reporting. As I think Mark was mentioning, that obviously aligning all of these data sets is one of the things that we really do need to work on, and to hear the things from Claire, and also from seeing a few slides from upcoming presentations. It's great to see that there's lots of work happening to try and collect this data and align it across health and social care. So these resident outcomes and system outputs, hopefully they'll come from the acute and primary care reporting, where we hope to see improvements such as patient flow, reduced length of stay, residents getting the right care at the right time in the right place, all at the same time of maintaining their dignity and respect for the residents' wishes and keeping the resident at the centre of the care. So moving on to the DSPT, and I do apologise if you're all aware of what the DSPT is, but just wanted to kind of show here that the Data Security and Protection Toolkit does allow organisations and independent providers to measure their performance, and that's against the excuse me, the 10 National Data Guardian's 10 data security standards, and that's been split down into 3 categories, so people, process and technology, I believe. So within the DSPT, there are 3 publications that can be achieved, or statuses that can be achieved. That's approaching standards, standards met and exceeded, or standards exceeded. And as of the end of April 2021, South East had 511 homes that were compliant with the DSPT. So that would be a 2019-20 publication or a 2021 publication above entry level, which was discontinued in March of this year. This information does come from the National Data Report, which is being collated by the Better Security, Better Care team. And again, that's very much in its infancy. We're still working with them. We're having weekly meetings to see exactly what we need and what we can get. But I can completely echo the issues and the challenges around obtaining that data, because obviously, as Mark said, care homes, the majority of care homes within our area are independent businesses, and it's quite difficult and can be quite challenging to get them to report, as we really rely on social contracts rather than having any contractual agreements with them directly as the NHS. So as the organisation completes their and publishes the toolkit, the information is held by NHS Digital, and they're currently working with teams, as I said, the Better Security, Better Care team, to ensure that that data is shared nationally. This information is really, really important and can really give us a lot of information. It's not only the status of the home's publication, but it can also highlight those homes that need to move on digitally to use the other initiatives such as NHS Mail. So looking at this graph, the uptake in NHS.net accounts has been phenomenal over the last year and a half, growing from pretty much 0 in January 2019, so that was pre-pandemic obviously, to over 2,700 active users, and this data I believe was from the beginning of April. So these numbers will have improved since that time, but it's really, really heartening to see that people are taking more of an interest in transferring data more securely. As you can see, the number of sites with NHS Mail has increased incredibly over the past year alone. So going from January 2020 from 500 up to 2,700 active users. You'll also note on the kind of orangey pink area at the top of the image that we do have a lot of NHS Mail users that do not utilise their accounts after setting them up. This can obviously be for many reasons, so we completely understand that there's a very transient workforce. People are always changing homes or moving from one to another, and also people do kind of get stuck in their ways and they don't want to change. So obviously the change management process is really helpful, because letting go of an email address that you've had for and used for years, it's quite difficult to let go of that. We do have a hygiene process that's currently in place where inactive accounts are deleted after a certain length of time. So that's kind of another ongoing piece of work, but very good to see such an uptake in such a swift amount of time. Obviously that's been fueled a lot by the happenings over the last year and a half. So moving on to proxy access. So what is proxy access? Once the care homes have completed and published their DSPT to a required standard, they can apply proxy access for repeat medications. Obviously, correct data sharing agreements have to be in place, and there is some paperwork that has to be completed. But for the collaborative workings, proxy access is to enable CQC registered care homes or care settings, GP practices and pharmacists to work together to allow care and nursing home staff to order online repeat medication on behalf of their residents. It was developed to allow someone other than the patient to access and manage parts of the resident's GP online services. So where the proxy user is basically given their own online access account rather than using the patient's login details, which unfortunately we did find a few of, which is not completely compliant with GDPR, but hopefully we're eradicating that. The access and consent, so GP practices can set up proxy access to repeat medications only at this time, meaning that care home staff can't see anything else in the record at the moment. If, however, the resident doesn't want care home staff to have proxy access to any of their record, including repeat medication, the care home must continue using a paper-based process for that resident. So all of the proper consent forms have to be completed. Communications, the systems demonstrated that there have been huge improvements to communications between care homes and their GP practice and or pharmacy, community pharmacy, as they can monitor the process of their orders online. So the care homes can basically go back in and have a look and see what how the order has progressed. And obviously then they don't have to be calling the practice or community pharmacy for updates as much. So it's freeing up telephones and telephone calls and allowing them to spend more time with the residents or the GPs with their patients. Scope for future use, as well as ordering medication, GP online services. The ambition in the future is to be able to give access to a resident's or patient's medical record, possibly test results, hospital notes and other correspondence, as well as appointment bookings and cancellings, all via proxy. So then the homes will be able to manage many more aspects of their residents' care, giving them a better overall experience of healthcare. In bold at the bottom there, I do have to say that GP surgeries do have the authority to refuse care homes access to the patient record, and that is most commonly found when the home is not compliant with the DSPT, so that they're not given the assurance that the home knows what to do with the patient information.
Just a minute or two, Darren, just to keep us.
Okay, this is the last one.
Thank you.
Excellent. So what are we doing to get the care homes up to the standards that we're hoping to? Obviously, again, we're still very much in the infancy, and we're really trying to build on this project and get the engagement. But so we've got NHSX and the Better Security, Better Care programme giving support for DSPT. That's one-to-one hand-holding up to webinars. There's many resources available on the Digital Social Care website with lots of different media to suit many different organisations. And also I mentioned Barclays Digital Eagles. They're doing basic digital skills training weekly and also incorporating support for DSPT and proxy access. So we'll be working with them on a more national level to make sure that they're giving the information and support that's required out there. As has been mentioned, we do have challenges in the way that we gather data due to the fact that many social care providers are independent businesses, and we aren't under contract to report back on a regular basis. This leaves gaps and leaves us with less robust data than we would like. This is being reviewed by colleagues from different organisations or from different teams. But if anybody has got any ideas or any support suggestions regarding the collection of social care data, I'd be really interested in linking with them. I'd be happy to share my email address if anyone would like to get in touch. And that's me.
That's brilliant. Thank you, Darren. There's a lot in there, and I'd imagine you'll get a few emails. Derek raised a couple of points, and I'd encourage you, Darren, to go and have a look at the chat perhaps during the next one. I think there's a recurring theme here about people thinking, well, and you touched on it with your assurance point, if you're going to run a care home, there must be some sort of license, there must be some sort of assurance process. And you would have thought in that conversation, contractual or otherwise, you could introduce, and you need to send us some data. and don't worry because these patients are consented for, and so on. And I think that's one of the big things that we'll kind of explore through the next few years, is that, because that outside of care homes is always the lever. So I work in a hospital, we sign a contract with the CCGs, we have to give them some data as part of that contract, and it shouldn't be beyond us to try and tweak that. Okay, Ellen, thank you for your patience. We're okay for time, so still got sort of 13, 14, 15 minutes or so for you. We've sort of collaborated because we're doing something similar down in Kent to what you're doing in London, which is around digital maturity. So very interested to hear what you've done and kind of learn from it, and see if we can use some of it in Kent and hopefully others elsewhere. So your slides are up, and over to you. Thanks, Ellen. And you're on mute.
Right, apologies for the fatal mistake. So thank you very much indeed for inviting us to attend. I'm Ellen Pirie. I'm a project manager at the Health Innovation Network, which is the academic health science network for South London. My colleague Ellie Eastwood is here with me as well. She's a senior analyst in our informatics team. And what we wanted to talk to you about today was the work that Ellie and her colleagues have been doing to build a London care homes digital maturity dashboard. So this is work that we are leading, reporting up to the London Care Homes Oversight Group and funded by Digital First, the London Region team. We're working with representatives from all 5 of the London Region STPs to take this forward. And our ultimate goal is really to create a user-friendly and useful care home dashboard for digital projects. Now, it was fantastic to have Darren before us because he's actually covered quite a few of these projects. So we I think, fit in very nicely as a complementary piece to that. So we're trying to pull together all of this data to report initially a relatively small number of use cases to ensure that data has a purpose and it's practical. We're bringing together nationally local data sets. As everybody said beforehand, getting hold of that is extremely difficult. Ellie has become a bit of an expert in pulling this data together, trying to keep it clean, trying to be sure that we've identified care homes correctly. We have 1,360 care homes in the dashboard in London currently. And then we also want to combine some activity data, LES 999 callouts and NHS 111*6 data to ultimately start seeing, can we see any kind of correlation between care homes have very strong digital maturity and capability, and how that links to their use of urgent care services. So we're looking to develop a digital maturity index covering a number of these different points to assess the readiness and capability. So just covering why is there a need for this? Well, I think, as everybody has said before us, getting hold of really good quality data on care homes is very difficult. There's quite a lot of data around, but it's not very easy to interpret. It needs a lot of work to kind of clean it up and make sure it's meaningful. It's quite difficult to keep track of which care homes are opening and closing and which provider groups they're part of. And if we've built a lot of data on one care home and it changes provider, we want to use the intelligence Ellie has developed to kind of take that knowledge with us rather than starting with a brand new entry. Again, Dan mentioned, difficult to keep track of which care homes have good IT infrastructure and needing help and support to take them further. So we've done quite a lot of work in South West London, particularly with Paul Harper and a team there who have a team of digital support officers who can go out to care homes and actually help them progress and move forward. So as you can see, we're also trying to track NHS Mail. I'll show you that in a minute with the use cases we're trying to cover. But one of the key things we're trying to do with this dashboard is reduce the duplication of effort in trying to pull this data together. Because what we were finding was that there were multiple project teams all trying to get hold of bits of this data, with a lot of overlapping kind of circles on the Venn diagram, and therefore it made sense to pull it together as one dashboard and do it once and then share it out to everybody. So that's why we're now trying to work with the 5 STP areas and the various project teams involved in the use cases that we're looking at. So initially the dashboard is being hosted on NHS Futures under the Enhanced Health and Care Homes workspace, and at the moment it's in the London region folder. So we have just posted up the dashboard into that folder, and we will be updating it monthly. Data is available at care home level, and then you can aggregate upwards. So the plan with this is to build it in 2 stages, taking us to September 2021, having what we've called the demographic information about all the care homes and the data items to cover the 5 use cases. And then we want to add the LES and the NHS 111 star 6 data. We want to also to look at a longer term provider and host for the dashboard, because I think the AHSN is seen as a good place to innovate and start this off. But we probably need to find a more robust model for taking it forward longer term. So we're looking to do that. We held a very helpful workshop at the end of March with attendees from across London, covering the different use cases, the different geographies, to get some feedback on the data items that we're looking to put in the use cases. And that was very helpful. And we have a meeting with the working group next week to take this forward. So the information that the dashboard holds is the demographics, absolutely critical, going back to Darren's point, to hold the information on the data security and protection toolkit status. We see that as kind of underpinning all of this digital work. So we include that. And then we're looking to have the data to support the use cases around the implementation status of NHS Mail. And it was interesting to hear what Darren was saying about that. We're finding it quite difficult to actually get really robust information about, is the NHS Mail account actually being used in a care home? We can know that it's been set up, but is it active, is it in use, is one of our discussion points. We're looking at the implementation status of the remote monitoring solutions that are being rolled out across London. I think there's 5 solutions that they can choose from being rolled out in different areas. We're also looking, as Dan mentioned, to track the implementation status of proxy access for ordering medications. In London, care homes are being encouraged to get access to the Coordinate My Care shared digital urgent care record system that is commissioned for the whole of London. So we're wanting to try and track and see things like how many residents have got a Coordinate My Care record. Are the care homes able to access and view? And then the final point, number 5, is a general technology deployment status. So this would be for things like the iPads that have been sent out. Can we see that they've actually been activated and used? And I think Ellie was saying that the recent data she's got on that shows that actually a lot of iPads have been sent out, but not huge numbers are actually being used currently. So the other thing the dashboard will then have, as I mentioned, a digital maturity index scoring system, which we're looking to develop with our working group. And then we'll also be adding in the LES and 111 star 6 data. We also have a slide on data security and protection toolkit because it's so fundamental. So you can see we've kind of shown in the middle there, it underpins proxy access, CMC, secure email, remote monitoring. It's a fundamental piece of infrastructure for the care homes. But I think, in discussion with our working group and others, we see it as something that you have to present it to care homes as, this is the electricity that we're putting into your home, but it's of no use to you without the light bulbs and the fridge and the gadgets that DSPT enables you to then access. So it has to be kind of discussed with care homes as on a what does DSPT get you, rather than doing DSPT just for the sake of it. So that is a key programme that we're trying to track the progress of in London. So I've covered that quite quickly. We weren't planning to show the dashboard just now because in the time available, it would just take too long to go through it and do it justice. But we can, as I say, it's on the NHS Futures EHCH workspace, so people can request access to that and can see it there. We can provide a link to that afterwards if people would be interested. So we're on to any questions, and I will, I'm sure, need to call on Ellie to answer anything technical that comes up here.
Thank you, Ellen. That's brilliant. Thanks for getting us back on time. Any questions for Ellen or Ellie? Just shout out, because I've kind of got the chat. And if you stop sharing your screen, Ellen, I can see a few more people in as well. But any questions, shout out.
So it's Paul here from Radio Ellie. I've just been triggered by NHS Futures mention there. Could we also share a link to the dashboard via the Open Data Saves Lives website as a possibly as a blog post, or and then it'd be searchable on the web as well, so that if people were finding it, they could just search Google and then maybe find it as well. Is that something we could possibly look at?
I'm sure look into it. Yes, absolutely. I can't see any reason why we couldn't. We hold absolutely no patient data or names, so there's no IG risk in this data, we don't believe. So I don't see why we do that, but we probably just need to confirm with Ellie and our team whether there's any issues with that, but I can't see why we wouldn't be able to do that.
That would be great. And I've got a question, and it's more for Paul and Stuart and the sort of the gang at ODI Leeds. One of the conundrums within all of this is that, as you said, Ellen, there's so many care homes and they open and close. And, you know, my job is easy in a sense because it's a great big hospital and, you know, it's not going to close. There's 4 of them in Kent. There won't be 5 tomorrow or 3. Is there anything, and maybe it's something to sort of think about and take away, Paul? I'm just sort of thinking of some of the great stuff you've done around geography and addresses and so on. Is how do we try and keep a really good up-to-date, you know, very simple data set of things like care homes, for example, in this example, that are constantly evolving and constantly changing. It's probably not a health question. It's more a, you know, a data question, I think. I mean, that's how all this started, you know, you as the geeks and us as with some little bit of knowledge about the health sector. It's something for us to kind of have a think about, because it's a constant conundrum. Because I suspect if Ellie came on, she would be talking in a similar way to the problems we have in Kent of just, is this a care home? Is this open? Is it closed? Does this patient come in from it? Is it closed temporarily because of COVID, or is it opened again? And just something for us to have a think about as a kind of resource, I think.
It's easy and hard. Okay.
So good.
It's you know, obviously the technology is there, but I think if we think about it in traditional ways, it's really hard. Which is, okay, we're going to have somebody who's responsible. We'll make one person responsible. We'll have one centralized database that will be accessed by these people. Okay, we need the IG for that. We need the security for that. We need the most successful things, I think, are distributed, federated models where people agree on a way to do this. And unfortunately, it does mean agreeing on a data standard, but the people who are closest to the care home are responsible for publishing that data. And then we cannot guess how that data will be used in the future. So we need to make it as easy as possible to use. So where I've seen building a distributed data set is sometimes harder to start, but much easier to maintain and update. So, for example, if in Kent, the right people to build this data, the register, so we'll call it a proper data register, would be you, right? Okay. So you put your hand up with beautiful information, we can be part of that. In Carlisle, it might be a third sector organisation that's working with care homes, right? They have some technical expertise. They've invested in it previously. They've won a bid. okay, they're the right people to do it, and they receive some additional funding to do that. In Scarborough, it might be a set of GPs who've set themselves up and they've actually invested in a whole load of data. So that's great, you know. It could be that we ask TPP and say, look, could you build us an extension to your product that just is a really simple thing for people to, oh yeah, well we could do that. Have you got any use cases? Oh, we've got these 3 things from Kent, Carlisle and Scarborough. Okay, all right, we'll just test it on that. And then all of a sudden, in 12 to 18 months, we've built the thing that we need. But it's really hard to specify and design that now because we just don't know. And also testing it in Cornwall, it might be a completely different landscape to what's happening in central London. Yeah. So,
I mean, great to see this, and the proof of that is the chat, because as you're talking, Paul, experts like Ellie and Polly and others are kind of going, and this is how we should start to do some of that. So it kind of, I would say it, but it proves the benefit.
Exactly. So they've got the geolytics thing.
And there's Stuart as well.
Yeah. So all of a sudden, without we haven't had to have a blooming. We have to go to Future NHS and have a blooming chat about something. It's all on the web. We're sharing things, and then we are okay. Right, let's go. So I think we need to find small money in lots of places to build a common data set around care homes, and then give it to someone grumpy like me to make sure it happens.
Yeah, with a very light touch guidance.
Exactly.
Some standards and some standards.
Yeah, we're gonna.
We're going to run out of time. We always try and get you away early, but we won't have achieved that today, which is my fault because of internet problems. Apologies. Fantastic presentations. Very grateful for everyone taking the time to do that. Darren, Claire and Ellen, it's been brilliant. We'll publish it all. Please look out for future ones. So we're planning a session in about a month, which we're kind of calling the diagnosis deficit. And this is what has happened in the last year in terms of people now going into ED, for example, that, you know, because they're on a waiting list, which has drifted out over a year and so on, how have the shifts of diagnoses that we're seeing, you know, who are those people who are too nervous to attend an A&E because of a very mild heart attack or very mild TIA or a stroke or so on. And we're going to try and start to analyse some of that, what has shifted in who's presenting at EDs, who's presenting at GPs and so on, and start to put some data around that. So please keep in touch. Thank you very much for your support. We'll be back in touch. We'll run these every month. We'll hopefully see you all in person in September and then probably in February in London, something like that. But thanks again and see you all soon. Take care.